Hello, everyone. I'm Dr. Liu from the Department of Pathology. Today, we will begin to introduce the pathological changes after injuries. The function and structure of normal cells are controlled by genetic programs for metabolism, differentiation, and specialization by adjacent cells as well as by the cellular environment. Most cells can adapt to normal physiological changes. Most stressful demands and some abnormal stimuli can initiate several functional and structural adaptations. Cells will be injured if they cannot adjust to the abnormal stimuli. Cellular damage is reversible up to a certain point. These changes are degenerative. If the stimulus persists or is severe enough, the cell reaches to the point of no return, cell death. These are the aspects we will discuss in this chapter: adaptation, degeneration, and cell death. There are many causes of cellular injury. Among these, the most important and common ones include hypoxia, physical, chemical, and microbiological agents, immunological reactions, genetic derangements, nutritional imbalances, and aging, etc. Here, I have a clinical case for you to think about. A 55-year-old man had a urinary tract calculi for a long time. This photo shows one side of his kidney. What has happened to this patient's kidney? Well, you might be able to answer this question at the end of this session. Session 1. Cellular adaptations. These are the major objectives. At the end of this session, you should be able to define the 4 types of adaptation: atrophy, hypertrophy, hyperplasia, and metaplasia. State the causes of cellular adaptation and describe their morphological changes. Adaptation are reversible changes. It is the non-injurious response to persistent stimulation and long-term effect from damaged factors. Here, persistent and long-term are important. Such adaptation can take several forms, including atrophy, hypertrophy, hyperplasia, and metaplasia. Atrophy is the acquired loss in size or number of parenchymal cells in a well-developed organ. In this definition, we should emphasize the loss of size or number, and it should happen in a well-developed organ. Undeveloped tissue and organs and tissues incapable of development cannot undergo atrophy. Atrophy can be physiological or pathological. We have many examples of physiological atrophy, such as atrophy of all organs and tissues in the elderly, atrophy of the thymus gland after adolescence, and uterine atrophy after delivery. The classification of pathological atrophy is based on causes. Local atrophy can be due to diminished blood supply. The schematic diagram shows us the brain atrophy due to atherosclerosis of the cerebral arteries. The other pathological events that can lead to atrophy include loss of nerve supply, loss of endocrine stimulation, inadequate nutrition, and sustained physical pressure on an organ or tissue. Pressure atrophy is caused by prolonged weight stress on the tissue. Pressure can be weak but persistent, so long-term is important and is the most common cause for atrophy. The left picture shows cerebral atrophy. Comparing to the normal brain, The parenchyma of this one is seen with dilation of the ventricles. Because of ventricular outflow obstruction, cerebrospinal fluid accumulates in the ventricles and presses on the parenchyma. Let's look at the morphological changes of atrophy. The pictures compare a normal heart with an atrophic heart. The atrophic heart has a reduced size and weight, a brown color and wrinkled envelope. The organ turns brown due to the accumulation of yellow-brown granular pigments, lipofuscin, in the atrophic organ. Here, I would like to mention a term, pseudohypertrophy. Atrophy of parenchymal cells might be accompanied by the hyperplasia of connective tissue and fat tissue, resulting in increased organ size or enlarged body part. This is not true hypertrophy, so we call it pseudohypertrophy. The second form of adaptation is metaplasia. One adult cell type is replaced by another adult cell type. In this kind of cellular adaptation, cells sensitive to a particular stress are replaced by another cell type that is better able to withstand the adverse environment. It occurs in homologous cells, which are cells from the same germ layer. In epithelium cell metaplasia, for example, columnar epithelium or transitional epithelium is replaced by squamous epithelium. The top picture is the schematic diagram of columnar to squamous metaplasia. These are normal ciliated columnar epithelium cells, and these are the reserved cells. In habitual cigarette smokers, reserved cells differentiated to become squamous epithelium cells. The bottom left photo is the normal ciliated columnar epithelium cells of the trachea. The bottom right photo shows normal cells of the trachea and bronchi replaced by squamous epithelium cells. Lung cancer may arise later in the metaplastic squamous epithelium. Glandular epithelium metaplasia, such as in chronic atrophic gastritis, refers to the replacement of gastric epithelium by columnar and goblet cells of intestinal variety. This is significant because gastrointestinal type carcinoma seem to arise from dysplasia of this metaplastic epithelium. We have discussed epithelium cells metaplasia above. The other type is mesenchymal tissue metaplasia. Connective tissue, skeletal muscle, and cartilage can be replaced by cartilaginous or bony tissue. Bone is occasionally formed in soft tissues, particularly in foresight of injury. Metaplasia is a double-edged sword. The advantage is it offers defense against external stimuli. The drawback is loss of normal function, and long-term metaplasia will induce cancer transformation. Now, let's summarize. In atrophy, we should emphasize loss of size or number in a well-developed organ. There are physiological and pathological atrophy. Physiological atrophy is due to aging and endocrine changes. There are several causes of pathological atrophy. Which one is most common? Yes, pressure atrophy is most frequent. Metaplasia is the change in cell type, and it is always pathological. Epithelium cell metaplasia is reversible. However, most metaplasia of mesenchymal tissue is permanent. Now, can you answer the question in our case mentioned in the beginning of this session? Here are the references and acknowledgement. This is the first part of cellular adaptation. Next time, we will discuss the second part. Thank you for your attention.